For my introduction, I wanted to perhaps give a different case study, or a case study, a little bit of a call to action right here on better access to health care, and maybe continue sort of my personal quest at this meeting to get the prevention and treatment of cancer onto the global health stage. The burden of cancer in mid and lower income countries is expected to increase from 60% to nearly 70% over the next 30 years. On top of this, in Africa, is the additional burden of the HIV epidemic. HIV increases the risk of cancer from some cancers anywhere like non-Hodgkin's lymphoma 20-fold to Kaposi sarcoma 2,000-fold. So I see attacking a new area with intelligence, new technologies, and the mindset of cost effectiveness can be really a health game changer for all. What we are seeing, again, is a laboratory in middle and lower income with respect to cancer. And if we start using some of the knowledge bases that we have, we will be able to actually introduce cost-effective strategies for cancer, which is, frankly, in the United States, bankrupting the healthcare system. And cost-effective approaches are needed by all.
I thought we might just deconstruct the title before we get into it, because the shifting nature of health, leveraging affordability to change the game. What do we mean by the shifting nature of health? I think we mean two things. I think Sally Davis raised one important thing, which is that the medical paradigm, of course, is to think about illness. And actually what we do need to do is think about health. And that is about behavior. It's about all the other stuff. And I think the other thing is the shifting of nature of health is the different expectations of health. And I don't think that the people who put up this building had an expectation that the life expectancy in many parts of the world would be what it is now. And equally, of course, the challenge of the huge disparity in life expectancy in different parts of the world. So I think that's the shifting nature of health. Leveraging affordability, I think, is simply about scale, actually. So an affordability we've discussed, it's not cheap per se, but it's fit for purpose. And changing the game, I think, is about quality. So it brings back the three things that we've talked about, which is scale, affordability, and quality. And what I really do want to move to and get in the discussion is the real world. What are people doing? What are you going to do?
I don't think we're doing a good job at molding possible or future innovators. I don't think we're doing a very good job preparing developers or implementers or policymakers or regulators or users of innovation. I think especially in this 21st century where everything is changing, and everything is changing around, the climate is changing. We're talking now about prevention and other things. I mean, we need to train, we need to educate. It's not only about technology, and people have said that. It's also about people, and the people that has to have an open mind. I don't know if in our countries, what happened is that we are so used to have nothing that we prefer to live like that. I mean, I always thought that in developing countries we were very creative, and that's what I got very, very, very frustrated when I heard these people not telling me what they wanted. But I think there is a lot to do.
A couple of big differences between the medical device area, which is very, very broad, from very inexpensive and simple scalpels and things to very complicated million-dollar instrumentation. So I'm trying to generalize here a bit. One is the IP. We heard about yesterday. Is that hundreds and hundreds or thousands of patents can cover certain devices. They're very complicated. But also the supply chain. You may have components in medical devices that are only produced by one or two companies in the world, and you simply can't afford to start creating those for the volume of medical devices that exist. 100,000 units of a medical device is hardly interesting at all to some large companies, and so they're not going to want to work with you on that, but you can't afford to make the investments it would require to build that technology for that very small volume, so you're stuck going to the existing suppliers with their commensurate costs, and suddenly you don't have, like in the pharma world, the opportunity to make a pill for pennies. You're making a device for just slightly less than the manufacturer makes it for right now. What I would predict, though, so if this happens, you can say you heard it here first, is this concept of we call store brands in the U.S., but large retailers will work with manufacturers to create proprietary brands which they sell, whether it's food or apparel or electronics. I wouldn't be surprised to see regional brands developing where they're working with the Medtronics or the Boston Scientifics of the world or the Abbotts to develop a product which they can brand and position and feature especially for their markets and price accordingly, which is tied to a large medical chain or even a government or some other regional major player, which they feel that product enhances their brand. So I expect we'll see some more of that activity in the future.
I think the innovation is, of course, technological. So we are working on new adjuvant, which allow us to, for example, develop new vaccines against malaria, in our case, or tuberculosis. And that's really new technology. So this new technology will open new opportunities to develop vaccines that we couldn't develop in the past. And we will see more and more, and I think I really agree with you, we will see more and more vaccines which are not worldwide vaccines, but regional vaccines or really specific to a specific disease in some part of the world. But if you only look at innovation through technology, you are missing a big part of innovation. And in fact, you cannot develop the next generation of vaccines. So we are really looking at innovation in the partnership. How are we co-developing our vaccines? How do we find the right partner to co-develop the vaccines? That's critical, because if you don't do this partnership, you cannot provide the affordable vaccines down the road.
I believe, from what I've heard, that we are really looking at several areas where action is needed. First is to bridge the gaps. Second is to strengthen systems. Third is to build partnerships. In terms of bridging the gaps, firstly, we need to bridge the gaps between academic disciplines of researchers. Clearly, we are looking at multiple disciplines that are required, not only within the traditional health disciplines, the public health disciplines, the biomedical disciplines, but several other disciplines which are going to be important in terms of engineering, in terms of social and behavioral sciences, and so on. All of these need to really come together, both to create new technologies as well as to evaluate new technologies. We have been talking repeatedly of ecosystems. We need to create an academic ecosystem of research which overcomes the ecosystems of individual disciplines. Then we need to bridge the gap between the innovator and the consumer. We have talked about people who are innovating but find that there is no consumer for it. That's because they have not been in dialogue with the consumer from the beginning, and we need to bridge that gap as well. We need to bridge the gap between the industry and the government. We need to bridge the gap between patent protection and public interest, between the price point and the pocket capacity of the consumer, and between the developed and the developing economies.